Hello, welcome to the EKG Guy and welcome to the EKG of the Week. I hope you're having a great week and I'm glad you could join us. This week's case is a 71-year-old male with a history of hypertension that comes to see you at your outpatient clinic. His EKG is shown here. Now before we get started, let's review the approach we've been using to interpret EKGs. So notice we have the patient's clinical presentation and the EKG below it. On the right side of the screen, we have a list that we'll go through before making our interpretation. First, there's the regularity of the rhythm. That is, are we dealing with a regular or irregular rhythm? And then if it's irregular, is it regularly irregular or irregularly irregular? Next, we have the heart rate. Then we'll look at the rhythm's origin. That is, where is the rhythm actually originating from within the heart? And then we'll look at and find the ventricular or QRS axis, which could help us with our differential diagnosis. Then there's the atrial, atrioventricular, and intraventricular conduction, looking at if there's any conduction abnormalities or not. Okay. Then we'll look at the waveforms, which would include all the waves, the segments, and intervals. And lastly, anything else, meaning is there anything else we have missed or still need to mention here? After that, we'll use all this information that we've gathered to make a final interpretation of the EKG. Now I want you to pause the video and take a few minutes to go through it yourself. When you're ready, start the video and we'll go through it together. Okay, so our 71-year-old male patient with a history of hypertension has this EKG. So let's take a look at it. First, what is the regularity of this rhythm? Well, on first impression of the EKG, you probably notice that the rhythm appears quite regular. In fact, this is a regular rhythm, okay? So with our regularity, we have a regular rhythm. So how do we know that? Well, let's look down here at this rhythm strip here in V5, and we'll look at the R to R intervals that are easy to make out, okay? And we're looking at constant R to R intervals, which is from one R wave to the next, okay? So we're gonna look throughout, and it should be the same. If you were to take your calipers out or a piece of paper and measure all these intervals out, you would notice that these R to R intervals are the same throughout here, okay? All throughout that rhythm strip, you'll see that they're just about the same, okay? So we call this a regular rhythm. Now, what did you get for the heart rate? Remember, this is a regular rhythm, so we can find this heart rate with a couple of ways. So one of the main ways that you can use for both regular and irregular rhythms is by knowing that the duration of the normal standard EKG is 10 seconds, okay? So from start until end, this represents 10 seconds. If you multiply 10 seconds by 6, that gives you 60 seconds, which equals 1 minute, okay? So that means if we count the number of beats going across the EKG, that will give us the beats, and then multiply that by 6, it will give us the beats per minute. So let's do that. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, okay? And maybe that one 12, okay? So let's say 12. So 12 times 6 is 72 beats per minute, okay? So that's one way we can find it, and you can use this similar approach with irregular rhythms. Now, another way we can use is by finding a R wave that falls on one of the thick lines, okay? So there's one right here, okay? So we'll use this one at this point here, and we'll count the number of thick lines to our next R wave, which would be here. So let's do that. Here's one thick line, the second, the third, the fourth, and it's between the fourth and the fifth, okay? So just over the fourth. So we do 300 over 4, which is 75 beats per minute, okay? And then 300 over 5 is 60 beats per minute. So it's somewhere between there, but closer to the 4, so it's closer to the 75 beats per minute, okay? So we'll write this here so you can have this. So 300 over 4 is 75 beats per minute, so approximately that. The actual rate here was 67 beats per minute, okay? So you can see that both these approaches give us a close approximate to what the rate is, okay? So the machine gave us an actual rate of 67 beats per minute. Okay, so those are two ways we can find the heart rate with irregular rhythms. Now to the rhythm origin. Well, we have narrow QRS complexes, so it must be supraventricular in origin, that is originating above the ventricles. We can also make out clear, defined, similar shaped P waves. So we have to ask ourselves, are we dealing with sinus rhythm? Okay, so let's look at this. How do we know if we have sinus rhythm? Well, we have to look at our leads in which the sinus P waves would be directed, okay? Remember, if we draw our heart here, this being our right atrium, our left atrium, our right ventricle, and left ventricle. Okay, and we have our sinus node up here in the upper right atrium near our superior vena cava. It has our internodal pathways that come to our AV node. Then we have the His bundle, it splits into right bundle branch. Okay, then the left bundle branch splits off into a left anterior and posterior fascicles, and both these sides end with these ventricular Purkinje fibers that innervate the cardiomyocytes. So with sinus rhythm, we're saying that it originates from here in the sinus node. That means the impulses from the atria are directed in this direction. Okay, so you can imagine if this was superimposed on this, and imagine our sinus node here, things would be directed in this region. Okay, remember the normal P wave axis is between 0 and positive 75 degrees. Okay, so we're saying that the leads that have this electrical impulse heading towards it will show upright P waves. Okay, upright P waves, because remember P waves represent atrial depolarization. Okay, so remember the leads would be 1, right? We have lead 2 here at positive 60 degrees, so somewhere around there. Okay, when we have lead AVF down here, another inferior lead, we have V4, V5, V6. Okay, you may also hear of AVR, which is placed here. Okay, and AVR is going to see inverted P waves because the impulse is moving away from it. Okay, now negative AVR would be here. That's simply the inverse of AVR. Okay, where we'd see a positive, but that's not on the standard EKG. Okay, so what we're saying is we want to see upright P waves in leads 1. Okay, lead 2, we want to see them in V4, V5, V6, and then possibly in AVF, and then we want them inverted in AVR. So if you look here, here's our upright P wave in lead 1. Okay, here's lead 2, so that's 1. Lead 2 also has upright P waves. Okay, then we said our lateral leads are on the precordial side. Here's V4, V5, and V6 showing upright P waves throughout these. Okay, and then in AVR, which is this lead here, okay, we see these inverted P waves there. Okay, so actually we are dealing with sinus rhythm. Okay, and there's a few other things that would push us towards that, and that's seeing P waves that have similar morphology. Okay, so all these P waves throughout, if you looked at them, have the same morphology, so we're not dealing with any ectopic atrial rhythm. In addition, we want to have a P wave coming before each QRS complex. Okay, so if you look here, we'll look at V5. Here's a P wave, and then we have our QRS complex, a P wave, and a QRS complex. This one here is our T wave. Okay, and if you went through this whole thing, you would see there's always a P wave with a similar morphology that's preceding a QRS complex, and there's always that 1-to-1 ratio, 1 P wave for 1 QRS complex. And because this EKG meets all of that, we are in fact dealing with sinus rhythm. Okay, so our origin is from the sinus node. Let's look at the ventricular or QRS axis now. Okay, so now we're looking at the electrical axis, and you should have gotten a QRS axis that is shifted leftward but still within the normal QRS axis range. The actual value here was negative 27 degrees, so I'll write that here. Okay, so negative 27 degrees. So let's see, how do we find axis again? Okay, so if you imagine, here's lead 1, lead AVF. Lead 1, the positive ends of these sit at 0 degrees, and this is at positive 90 degrees. Plus or minus 180 degrees would be here, and this is negative 90 degrees. Remember, normal axis lies between negative 30 degrees and about positive 105 or positive 110 degrees. Okay, so all this region here is considered normal. This would be our right axis quadrant, right axis deviation, left axis deviation beyond negative 30 degrees. And then we have our extreme axis shift, that's rare, there on that rightward superior axis. Okay, so what we're looking for here is we're going to look at leads 1 and leads AVF first. Okay, so lead 1 here is upright and positive. Okay, so we're going to go towards the positive end of lead 1. If we look at AVF, we see a negative complex. So we're going away from the positive end, which means we're going to be now in this region here. So now this puts us in a little dilemma. Are we actually dealing with a leftward shift that is still normal, meaning that it's below this negative 30 degrees, or is it beyond negative 30 degrees, in which that's more of a pathological leftward shift? Okay, so how we do that is we need another lead to look at, and in this case we look at lead 2. Okay, and so where is lead 2 normally placed? So lead 2 is actually right here, and it sits here at positive 60 degrees. Now the perpendicular of this lead 2 would actually come right here, which is that negative 30 degrees. That means if we look at lead 2 and it's positive, it will put us on towards the positive end of lead 2, and in this region here, let me use it, and right over here. Now if lead 2 was actually negative, it would put us over here and in this pathological leftward shift region. Okay, so let's look at lead 2. I'll erase this so you can see it a little better, okay? And lead 2 is this one here. And notice that our lead 2 actually shows isoelectric QRS complexes. So pretty much isoelectric, meaning the positive portion of that QRS complex is almost equal, if not equal, to the negative portion of that QRS complex. And because of that, if it's isoelectric to this positive 60 degrees, it pretty much lies on this negative 30 degrees line. In fact, the axis was negative 27 degrees. Okay, so negative 27 degrees would be about right here, which you can see that's somewhat in our normal region. And remember, as we get older, our patient here is 71-year-old male with hypertension, okay? So hypertension is the thing, possible left ventricular hypertrophy, because that left ventricle has to overcome that additional pressure getting blood out through systemic circulation, so it will get bigger, and because of the left ventricle getting bigger, okay, it will hypertrophy and shift the axis more leftward, okay? And also with age, remember, children when they're born have more of a rightward axis, right, from 32 weeks gestation up until about that first month of age of life, and then slowly it starts to shift more leftward as we get older, okay? So older adults will have more of a leftward axis. In this case, negative 27, okay, possibly right on that borderline considered leftward axis, okay? So how about atrial conduction? Well, typically we look at leads 2 and V1 for P wave or atrial abnormalities. The P wave duration appears within normal limits here, that is less than 120 milliseconds or 3 small boxes, okay? So remember, we look at lead 2, which is right here, and we're looking, when we look at atrial abnormalities, we're looking at things, problems with the atria, okay? Remember, what represents atrial depolarization? Well, our P wave, so that's where we look for problems with the atria. And V1, which is like a short axis view of the heart, of our atria, okay, gives us a good idea of what's going on, okay? And you can see our biphasic P waves there are actually normal in this case. So in this case, atrial conduction is normal, normal duration, and normal amplitude of our P waves there. So how about atrioventricular or AV conduction? Well, in this case, we are looking for any conduction delays as the impulse travels between the atria and the ventricles. Because the majority of the PR interval represents the AV nodal conduction, we're going to look there. The normal PR interval in adults is between 120 and 200 milliseconds, which is the 3 to 5 small boxes. Here, the PR interval is within normal limits, and it actually was 174 milliseconds, okay? So the PR interval, just so you're aware, was 174 milliseconds. That's within that 120 and 200 millisecond range. Okay, so this is actually a normal PR interval. Okay, so remember, when we look at the PR interval, that's if this is our P wave and this is our QRS complex, the PR intervals from the beginning of our P wave up until the beginning of our QRS complex. Okay. So hopefully that makes sense. So we have normal AV conduction, no AV blocks present, as well as no short PR interval present here when we would think of possibly a ventricular preexcitation syndrome. Okay, so normal AV conduction. Okay, next we have intraventricular or IV conduction. Here we look at the duration of the QRS complexes. We have normal QRS duration, remember, is between 70 and 110 milliseconds. That's about 2 to 3 of those small boxes. The main thing we're looking for here for IV conduction is that QRS interval is prolonged or not. Okay, so that's the main thing I want you to think of when we talk about IV conduction. Is the QRS complex prolonged or not? Meaning, if this is the start of our QRS complex until the end of it, okay, is that prolonged or is it normal? Okay, so that's what I want you to look at. And here we can see narrow QRS complex that appear within normal limits. In fact, the QRS duration here was 86 milliseconds. Okay, so that's the QRS interval. Remember, between 70 and 110 is normal. So we have normal IV conduction, we had normal AV conduction, and we had normal atrial conduction. So how about the waveforms? Well, P waves we said were most likely normal here. There's no significant P wave prolongation or increase in amplitudes in leads 2 or V1. No abnormal Q waves are present. The T waves are present, they're asymmetric and appear normal. The T wave amplitude is typically greatest in leads V2 and V3. Okay, so here's V2 and V3. Normally you'll see those having the greatest T waves present, okay, in those precordial leads. The PR segment is not significantly depressed or elevated anywhere here. The PR and the QRS intervals we said were within normal limits. The QRS amplitude appears somewhat increased on initial inspection of the limb leads. However, on closer evaluation, it's really only lead AVL that has an R wave that is about 11 or 12 millimeters in amplitude. And remember, the voltage criteria for AVL with regards to left ventricular hypertrophy is an R wave amplitude of at least 11 or 12 millimeters. Okay, so for left ventricular hypertrophy, one of the voltage criteria is that in AVL, okay, you can have an R wave that is greater than or equal to 11 or 12 millimeters. I say 11 or 12 because depending on what study or what book you read, you'll see 11 or 12. Okay, so it's at least 11 or 12, and that's what we see here. So here's lead AVL, okay, and we're looking at the amplitude of the R wave, which is, let me use a different color. This wave here, here's another R wave. So from the top to the bottom, okay, you can see it's about 11 millimeters here, so maybe it meets the criteria. So that's one voltage criteria met for possible left ventricular hypertrophy, although we also need non-voltage criteria to be met, such as an increase in R wave peak time in leads V5 and V6, slight QRS interval prolongation, here we said it was normal, or secondary STT changes. None of these non-voltage criteria are met. The only supporting evidence of left ventricular hypertrophy here is the more leftward shift in the ventricular axis. We saw negative 27 degrees right on that borderline thing, as well as the patient's history of hypertension, right? Our patient has hypertension, and because of that, remember, the left ventricle may hypertrophy to get bigger and overcome that systemic resistance. And that's one thing that can support this. Otherwise, there's no supporting evidence of left atrial enlargement or prominent U waves that may sometimes be seen with left ventricular hypertrophy. Anyways, the main thing here is that the minimal voltage criteria for left ventricular hypertrophy is met in lead AVL, but may simply be a normal variant in some cases, and even here. So hopefully that makes sense. Okay, so how about the ST segment? Well, the ST segment does not appear significantly elevated or depressed anywhere on the EKG. The QT interval appears within normal limits. The QTC interval was actually 418 milliseconds here, which is within normal limits. Remember, the QTC interval corrects for heart rate, okay? So overall, there's no major waveform abnormalities here, okay? And what I'll put in this case is this minimal voltage LVH, or left ventricular hypertrophy criteria, possibly met, okay? And then is it a normal variant or not, okay? Possibly, okay? Because we don't have that non-voltage criteria to support it or any other evidence or history from this patient. So is there anything else we're missing here? Well, not that I can see. The R wave progression in the precordial leads appears generally normal here. There does appear to be something going on here in leads V3 and V4, but may simply due to misplaced leads as the R wave in V5 regains its dominance. Okay, remember, the R wave progression means that the R wave amplitude should increase as we go from V1 to V2 to V3, V4, and V5. Okay, we should see an increase in our R wave. So here's the small R wave, here's another R wave, another one, and notice how it gets smaller in V4. Okay, this is our R wave, and then gets bigger in V5. It's kind of weird from going a larger to a smaller to a larger, so it may actually be a misplaced lead on this EKG that's causing that. Okay, now the transitional zone in the precordial leads also appears to occur between leads V2 and V3. This transitional zone is simply the precordial lead area where the QRS transitions from mostly being negative to mostly positive, with the actual transitional area to be where the QRS complex is isoelectric. Normally, the transition occurs between leads V3 and V4. If it occurs earlier than V3, we call this a counterclockwise rotation or early transition. And if it occurs after lead V4, then it's considered a clockwise rotation or late transition. So because we have it occurring here before V3, this is technically considered a counterclockwise rotation or early transition. Okay, so remember, we're going we're saying that we're going from being mostly negative, here's mostly negative, okay, and it seems like it's starting actually to become even mostly positive between this region here, so maybe it's between V1 and V2, okay. Anyways, it's occurring before V3, so again, we call this a counterclockwise rotation, okay. Or an early transition. Remember the normal transitions between V3 and V4. Anyways, the main thing here that I want you to keep in mind with R wave progression in transitional zone is that it's really highly dependent on lead placement. Okay, so I really, make sure they're in the right place and before you make and use that in your interpretation. So what's our final interpretation? Well, we have regular sinus rhythm occurring at a normal rate, right? Our rate here was 67 beats per minute, along with normal atrial, AV, and IV conduction. We have no major waveform abnormalities and the minimal voltage criteria for left ventricular hypertrophy that was met in lead AVL. So this is a case of normal sinus rhythm with minimal voltage criteria for LVH, or left ventricular hypertrophy, and overall considered a borderline EKG. Okay, so I'll erase some of this here, and what I'll say is that we have normal sinus rhythm, okay, and we also have that minimal voltage criteria met for LVH, okay, and that was in lead AVL, we saw it, so just so you can go back to that. And the other thing is that this is we consider this a borderline EKG, okay, borderline normal or abnormal, okay. So in conclusion, our 71-year-old male with a history of hypertension has an EKG that shows normal sinus rhythm and potential evidence of left ventricular hypertrophy. Well, that's the end of this week's EKG of the week. I hope you learned something. Please don't forget to like this video and leave a comment below if you like what we're doing. In fact, many of you have asked how you could help us out. Really, the best way would be to simply subscribe and share this resource with your friends. You get free access to more than 300 videos. There's also a community of over 125,000 of us like-minded individuals on Facebook. So stop over and join the EKG Guys Facebook community. If you need a crash course on EKGs, we launched our new EKG course recently. Check the link below if you're interested. The original cost is around $150, I believe, and I made it less than $20 for a limited time. I may be biased, but after reading nearly every EKG textbook on the market, I think this is by far the best EKG series to take you from a beginner to a physician level in no time. Anyways, check it out for yourself. I think you'll really enjoy it. And of course, check out our brand new website, ekg.md, the premier EKG resource for medical professionals, where you'll find more lessons in practice. That is www.ekg.md. Last but certainly not least, leave your feedback because it's incredibly helpful and your kind words are always an encouragement on those long days. So let us know how we're doing. Thank you again for your support. It is truly appreciated. We are the largest, fastest growing EKG resource in the world.